Okay, good afternoon. I want to say thank you to Maureen and my HPO colleagues for inviting NOCA not to do just one presentation but two today. So I reckon we're really important. Worth your while to stay and listen to us. Secondly, I want to thank Colette who gave me this title. Don't know how I'm going to live up to it, but here we go. And it's not starting well. Which one goes forward? Oh, yeah. And there's the Quality Street. And you might all think we're talking about chocolates today, but we're not. In fact, do you want to know where Quality Street came from? It was a 4-act play written by the author of Peter Pan, J.M. Barrie. We're going to have a bit of a more grown-up conversation today, but there's still 4 acts. The first bit I want to talk to you about is about NOCA, National Office of Clinical Audit. Who we are, what it is we do. And Louise has already talked to you about National Clinical Audit, what it is. It's a systematic review of care against clinical standards to measure patient outcomes. And that's what our National Clinical Audit will do. And if you think of it in that way, what clinical audit is a dashboard for clinical care. And what we in the National Office of Clinical Audit want to do is to have good data to facilitate good decision making at a local level and importantly too at a national level. The National Office of Clinical Audit, we were founded in 2012. We are funded by the HSE Quality Improvement Division, and I know some colleagues are here today. And we're operationally based in the Royal College of Surgeons in Ireland. Our job is to design, implement and manage national clinical audits, and we provide governance standards around those. And I'm going to go into that in a little more detail a little later on. What do we do for hospitals? Well, these audits are implemented at hospital across the acute hospital sector at the moment. We provide hospitals with reports on a regular basis throughout the year, and we also provide national reports at the end of the year. Where there are outliers, we inform both the local hospitals and we escalate those within the system. And we also promote the use of national clinical audit data. And I think Louise mentioned some of that a little earlier today. We also, in addition to that, provide training programs and support for our national clinical audits. We are beginning now, and I think Louise already mentioned, to carry out research studies arising from national clinical audit, and we share the learnings from within those national clinical audits as well. This is our portfolio of national clinical audit. There are currently 8 within that portfolio, the first 6 of which are fully implemented. And the National ICU Audit and the National Orthopaedic Register are currently in implementation, due to be implemented in 2018. I suppose what I'd like to say is we don't do these on our own. We work obviously with our colleagues in hospitals to implement these, but with a number of stakeholders throughout the system. But today I want to, and as Louise has done already, want to acknowledge the work with we're working with the HPO in presenting these or in facilitating these audits to the system. I suppose our National Audit of Hospital Mortality uses exclusively HYPE data and analyses HYPE data to provide a mortality analysis. We use HYPE data to validate our findings from major trauma audit, from some of our NPEC audits, and we'll also be using it in our Irish National Orthopaedic Register. The Irish Hip Fracture database also validates against the HYPE data, but uses HYPE to collect their information as well. And I know our NPEC colleagues work very closely with the NPQRS. So none of these audits happen in isolation. They're as a result of working with a number of stakeholders in the system, but also working with our hospital colleagues in the system. So this is what we do. This is how we design, we implement, we manage our audits and the output that comes from them. And this probably is a substantive part of my talk today. I'm going to talk about aspects of designing audits, aspects of implementing audits, aspects of managing audits, and aspects and the outputs coming from that. And what we want to do through this is provide quality data to inform the system, and from that to promote good patient care. and there has to be a suite. And for each audit, when we're starting off and designing them, each audit we must define what it is we're going to do. Each audit has an overall aim and has specific measurable objectives. These are the aim and objectives of our National Major Trauma Audit. By doing this, we can benchmark the performance of our audit, and we can look at this at year end to see how we are actually performing. So, for example, for major trauma audit, providing a high quality data to, starting at number 1, a national baseline clinical practice. We started this audit in 2013. We published our first report last year. We have now achieved data outcome. Identify and map and potentially improve current pathways. We certainly have identified areas for improvement at both a hospital level and at a national level. Promote reflective clinical practice to encourage performance review at a local and at a national level. We do this through our feedback and our reports and through our monitoring and escalation policy, and I'll give you a very good example of that a little later. And provide high-quality data to enable peer-reviewed research to drive clinical change. In our major trauma audit now, we have over 12,500 approved submissions. We have a number of research requests who are just starting to mine our data to carry out research on trauma in an Irish context. This is hugely exciting. This is what will really change things in the future. To provide good data, we need good information governance system, and these are some examples of what we do across some of our audits. We ensure compliance with agreed definitions and comparability, working to agreed messaging standards, using SNOMED for our national ICU audit, using ICD-10-AM definitions for a number of our audits such as NAM, INOR, IHFD and major trauma audit. We look to provide data quality standards and frameworks across all of our audits. We provide data dictionaries to ensure we understand what it is and within NOCA and within the hospitals understand what it is we're collecting. We provide ongoing training to all of our, we provide training at the commencement of every audit and ongoing training on an annual basis to everybody participating in our national clinical audits. We appreciate that our reports may not provide enough information. We have policies governing access to our information, both for a quality improvement and service evaluation requirement, but also for research. Good information governance policies are important to see how this information is being used, what it's being used for, and the output of that. We disseminate reports, as mentioned, to our hospitals quarterly throughout the year. And at year end, we produce an annual report from each of our audits that have been fully implemented. We produce also patient and public information, and I'll talk to that a little later. To provide good quality data, you need to manage your IT resources well. And some of our audits obviously have a more significant IT resource than others. But to do that, we provide governance around the management of these IT resources. We ensure security testing, and we ensure that all of our applications that we develop ourselves go through rigorous testing before they go into use. Louise has already presented the national audit, the Irish Hip Fracture Database. What's really important about this slide is one national clinical audit equals 16 local audits in the case of hip fracture, 26 in the case of major trauma, 44 in the case of mortality. And each of these local audits are individually important to the hospitals. So what the hospitals need generally to implement these audits. They need local clinical champions as an audit coordinator to collate and collect the data, and also to feedback reports and work within a governance structure, and a local clinical lead to provide support to that audit coordinator. But in order to support those clinical champions or those clinicians, to carry out this audit, there needs to be a governance structure within the hospital which provides oversight for the national clinical audit, as well as supporting the the clinical lead and the audit coordinator. This can be done by means of a local audit committee at a directorate level. In smaller hospitals, audit reports have been taken directly to the Executive Quality and Safety Committee. No matter what the mechanism is, it is really important that the local audit coordinator and clinical lead are supported in order to manage the clinical audit and thereby then invest in improving patient care. This is an example of how it can work really well, and it's an example I've taken from our major trauma audit national report from last year. And it's a case where that was reviewed at a local hospital that has led to a number of changes. And I suppose what's important is the case review an individual case review doesn't mean something went wrong. It's something where you can learn from and make things and improve things for patients in the future. And this is a case where an elderly gentleman was admitted with fractured ribs, which were diagnosed following chest X-ray. He was treated for those. However, his condition deteriorated, he developed cardiac complications, and his condition continued to deteriorate, and he died a number of days later. This case was reviewed by the local audit coordinator and clinical lead, and importantly supported by the Quality and Safety Committee within that organisation. And that led to really important changes within that organisation. Implementation of a sepsis pathway wherever Vita and Christina are, and sepsis screening and appropriate escalation of care within that organisation, showing how clinical audit can improve care at a local level. Another important part of ensuring good data is training staff. And I suppose this is equally about staff in NOCA to ensure that we are providing as good a service as possible, but also about the staff, the people working in hospitals carrying out our audits, whether they be our clinical leads or our audit coordinators. And this is something we take very seriously. We don't do it ourselves. We work with our audit partners and with our colleagues, but also in terms of our audits, it's an important part of we provide an annual update and training from each of our audits. I mentioned the importance of a local governance structure, but I also just wanted to highlight our governance structure within NOCA to facilitate our national clinical audits. What you can see here is that each of our national clinical audits has an identified clinical lead. They work to an individual audit governance committee. The role of that governance committee is to oversee that specific audit and the strategic direction of that specific audit. Oversight for all of the audits within our office and National Clinical Audit in general is provided by our NOCA board. Our clinical director, Mr. Ken Mealy, is here, and Colette Tolley, our executive director. The chair of our board is Professor Conor O'Keane from the Mater University Hospital. As you can see, we also work with our colleagues in NPEC who report directly into our board. The role of the board is very important, not only in providing oversight for our office in general, but also approving of all of our national reports. An important part also of National Clinical Audit is oversight of that audit. And to do this, we have our National Monitoring and Escalation Policy. And I see this in two ways. One, it supports hospitals to identify particular issues for review. And secondly, it is our job to inform the system where should these issues not be addressed. This is just an example from the National Major Trauma Audit of issues that the National Major Trauma Audit Governance Committee monitor closely. One around data quality and two around hospital survival. It is the job of each individual Audit Governance Committee to identify performance indicators which should be reviewed. That's how we go about ensuring we have good audits and good data. And what is all this for? But this is all about improving patient care. And in the next act of the play, I just want to take you through some examples of the audits improving patient care. And of course, this is chocolate. Okay, the National Major Trauma Audit, as I mentioned, provides reports to the hospitals on a regular basis. And we've seen one example of local improvement. In 2016, the National Major Trauma Audit was endorsed by the NCEC. What this does is prioritises trauma audit and trauma care within the system. And I think this has been very important, and this will be very important in terms of resourcing our audit. We also published our first trauma audit report, but we're providing continuous information back to the system as well. Our national ICU audit provides regular reports to participating hospitals across a number of key indicators. Just there on your left, which include mortality, unit-acquired infection, readmission rates, and so on. And these are really useful quality indicators. From this audience perspective, what might be even more interesting is the National ICU Audit will support HYPE and ABF, and will support HYPE and ABF in terms of providing detailed information around what happens behind those closed doors of ICU, what organs are supported, and all of that. So that is really, really important. And if they weren't doing enough already, there are many strings to this audit's bow. They also provide governance to the paediatric audited intensive care network audit, an audit of paediatric intensive care. They will also provide reports to Organ Donation Transplant Ireland. They're developing key performance indicators for the system, and examples of international key performance indicators occur around readmission rates to ICU, standardised mortality rates, and this will also support the development of a national ICU bed information system, providing information on availability of beds within critical care. We all have a lot to keep up to. Our Irish National Orthopaedic Register, and I think is really, really innovative development. This provides real-time data collection at the point of clinical care. And what you can see here is, the top photo is a patient in the pre-op assessment clinic carrying out a pre-operative assessment. The second two photos are a surgeon who has completed his intraoperative note and taken it off the system. And the final part, John, which you might be particularly interested in, is component scanning intraoperatively. Real-time data collection, reducing the burden of data collection for audit. That's really, really important. Let me just mention, this is an international first. This is live in the St Infirmary University Hospital in Cork and in the Midland Regional Hospital in Tullamore, and is planning for and implementation for Kappa and Croom orthopaedic hospitals at the moment. And I suppose the other thing is this provides a clinical audit function for elective hip and knee transplant. Elective hip and knee transplant. But it also provides a traceability register. And we had a preview at how well this worked earlier this year when there was a safety notice issued by the HPRA, and we were able to identify where all of those implants went. So this is going to revolutionise, or this is be a real game changer here. Okay. I suppose that's really important, the information we're giving back to the system about improving patient care. But I think something that struck me very recently was at the launch of our NAM audit. This is my favourite suite, so this probably is the most important piece to me. It was something that Brian Armani, our public representative on our NAM governance committee, said, and I've put it up here exactly more or less as he said it. And I suppose what was important, or I suppose why it struck such resonance with me was, he said, is in what he said. And I suppose I thought, if we can conduct our audits in this way, and if our audit outputs can achieve this, we are doing some good. So what Brian said is, behind this report, when we launched the NAM report, lies the everyday drama of life and death of real people. Every incremental improvement, no matter how small, in every hospital, in this and in every future report, will be a small victory for the individual who survives, for their families and loved ones. So I suppose, when we're getting carried away in the mire of what it's all about, and and sometimes being, hitting roadblocks, if we remember this, I think this can inspire us to keep us going. I suppose, what are we doing in NOCA to be as patient-centred as we possibly can? We have a suite of information leaflets for the patients and public to inform them about each of our individual audits. When we start off to conduct a new audit, we carry out a full data protection assessment, but we also carry out for new audits, a privacy impact assessment. That's going to be a requirement now with the forthcoming HICWA information standards. But more recently, our board approved our public patient involvement framework. And this will govern how we in NOCA will engage the public and patients in our audit. How in our audit governance committees, in designing our programs, and so on. And I think this is going to be this is very important for the work we do. Consent, of course, is a very important topic, and I suppose having having the patient centred having the patient at the centre of what we do has governed how we've built our systems. So for our Irish National Orthopaedic Register to gather personal information within the register and to retain it, we need consent for from that patient and from that individual. And that only if that individual gives us that consent and we retain it on the system, will we collect that personal information. So engaging with patients, having patients at the centre of our audit or having patients at the centre of what it is we do will determine how it is we do it. Okay. I suppose what I hope I've shown you is what it is we do it, why we're doing it, how it is we're doing it, and why it is we're doing it. The importance, I think, to the health system, but also perhaps to our family, our friends, and by holding that at the centre of what we do, I think we will all do it better. These are our contact details for the National Office of Clinical Audit. Thank you very much for your time.